Perfect. All right. Well, I'm going to go ahead and open grand rounds for the Department of Medicine on this last grand rounds of January 2024. And I'm going to welcome our guest today, who is Dr. Ned Waller from Medical Oncology. Dr. Waller received his undergraduate education at Harvard, his PhD from Rockefeller University, and an MD from Cornell University. He then completed his medicine residency and medical oncology clinical fellowship at Stanford and his postdoctoral training with Dr. Irv Weissman. His focus from the get-go was human T-cell development from stem cells. And then he followed with his research group at Becton Dickinson in San Jose, California, focused on characterizing hematopoietic and stromal stem cells. Later, he joined Emory, where he has served as the Associate Director of Clinical Research for the Winship Cancer Institute. He has led Emory's BMT program, is the Director of Regenerative Engineering in Medicine, and holds the Ryan Searle Professorship in Cancer Medicine. He was part of the 1998 inaugural group of the Doris Duke Charitable Foundation Medical Research Program grantees to study enhancing immune reconstitution in cancer patients. He's conducted translational and clinical research in cancer immunology for the past 25 years. Dr. Waller is also a clinician scientist entrepreneur, and he co-founded Cambrium Medical Technologies to develop a topical therapy for ocular GVH, as well as co-founding Cambrium Oncology, a preclinical startup to develop a novel immune checkpoint drug targeting the receptor for vasoactive intestinal peptide. He currently serves as the editor for Immunomedicine and chairs the Translational Immuno-Oncology Study section at the NIH. I have collaborated with Dr. Waller many times at the bedside of the bone marrow transplantation patients that he cares for, and know him to be also a very thoughtful clinician and a future, forward thought leader in thinking about utilizing immunotherapy and T-cell therapy. And so I'm super excited that you are here to talk to us today about the past, present, and future of CAR T-cell therapy, which I think we are going to encounter more and more and more and need to understand better over the course of our lifetimes as physicians. So Dr. Waller, thank you so much for joining us this morning or this early afternoon, and I'm grateful and excited to hear your talk.
Great. Thanks, Wendy. Thanks for the kind introduction. I'll share my screen and we'll get going. Can you all see that?
That's perfect.
Okay, super. So I'll give a little overview of CAR T cells. It's a very big field now. I won't be able to cover every aspect, but just to give you some historical perspective, Emory's experience with CAR T cells and some future developments that we hope to move forward. I have some financial conflicts of interest as I consult for some companies, and as Wendy mentioned, I founded a couple of companies which I hold founders' equity in. And I actually hold stock in Doximity. Doximity was co-founded by Nate Gross, who's a former Emory Medical School graduate. I got an email that I could buy at the IPO price, and I did that. And it's not made me a lot of money, but it's fun to see stock go up and down and wonder why. Usually I have no clue. I'll talk today about synthetic biology, which is redesigning organisms or cells by engineering them to have new capabilities. And CAR cells are really an exemplar of this approach. Just to sort of give everybody a little grounding in CAR cells, and particularly CAR T cells, but we'll see there are different varieties of CAR cells. There's been an evolution over time, and the basic idea is that we can cause expression of a antibody on the surface of the cell that then signals to the T cell, in this case, as if it's a T cell receptor. And the evolution has been to move from a single signaling molecule, CD3 zeta, to two signaling molecules, CD3 zeta, and a co-stimulatory molecule to mimic what the T cell would see if it was engaging its T cell receptor with an appropriate co-stimulatory molecule, 4-1BB or CD28. And then there are subsequent elaborations onto this approach that we'll go into as we talk. Really, the modern field of CAR T cells started with Emily Whitehead, who is literally the poster child for CAR T cells. She was a 7-year-old girl dying of leukemia in a Children's Hospital of Pennsylvania in 2012. She had a disease that at the time was pretty treatable, but she was one of the unfortunate children whose disease did not respond to first-line therapy, did not respond to second-line therapy, and the doctors who were treating her outside of Philadelphia recommended to her family that she go to hospice. A CAR study had recently been opened at University of Pennsylvania. It had treated 3 patients with CLLs. She was referred there and went through the treatment and really had a horrific course. She had lots and lots of toxicity, was dying from cytokine release syndrome, and finally was salvaged with tocilizumab as the niece of Carl June had rheumatoid arthritis, and he was aware that she'd received tocilizumab for her condition, and Emily's treating oncologist, Steve Grupp, recognized that high ferritin levels were seen in macrophage activation syndrome and hemophagocytosis, and they decided to treat her with that drug, and she had a miraculous recovery. She's now a freshman at UPenn, so it's sort of full circle for Emily. And I think that showed in an N of 1 that treatment of refractory cancer was possible with CAR T cell, and it ultimately led to commercialization of these products. This is a schema of CAR T cell receptor technology. The basic idea is harvesting cells, some type of mononuclear cell, from the patient or potentially an allogeneic donor, selecting a subpopulation of those cells for manufacturing. I've illustrated this with the blue cells that still have some degree of heterogeneity, and then genetically modifying them so they will express on their surface a receptor that can target them to a particular cell or tissue in the body, infusing them into a patient, usually after the patient has received treatment to depress their own level of lymphocytes, giving space for these new cells to grow. And then the genetically modified cells go through the body, in this case, target cancer, which is present in the lung and the liver. So this is the basic big picture. I'll break this down in a series of points, first talking about the spectrum of chimeric antigen receptor cells. It's not limited to T cells, and I'm sure we'll see increasing examples of CAR T cells used for a variety of indications, not just cancer and not just using T cells. I'll talk a little bit about some of the toxicities that we see, and then I'll end with CARs which are going to be manufactured at Emory, addressing some problems in the field, limitations in manufacturing processes, predicting responses, and overcoming the immunosuppressive tumor microenvironment. So let's go through some basic principles of chimeric antigen receptor cells. First is we need to identify a target antigen. We can think about antigens which are physiologically expressed in the body versus antigens which are ectopic and not normally expressed, like cancer antigens. We have to think about their tissue distribution and in the antigen density. In the talk, I'll try to touch on the areas, some important areas I've highlighted in red. The black areas are still important, but because of time limitations, we can't cover everything. Second, after thinking about the antigen target, we think about the binder. What is it on the CAR cell that's going to attach it to that antibody or to that antigen? And one can look at chimeric antibodies in the example I already gave you, but we can also look at other ways of attaching the cell to the target, including receptors for a surface-bound ligand. Thirdly, the properties of the cells. What does the cell do after it binds? Is it killing the target, or is it producing some other molecule that may change physiology or address pathology? Is it an autologous or an allogeneic cell? What are the conditions in which it has been expanded in the laboratory, and how will it expand in vivo? How long will it persist? Where will it go, and how long will it live there? And finally, does it work? What are the on-target effects of the CAR? What are the off-target side effects of having an activated cell population in the body that may cause other organ dysfunction? So one can look at this from the standpoint of the different aspects of CARs in 3 dimensions. There's the targeting molecules, which can be antibodies, receptors, or ligands. There are the payload molecules, cytolytic function. The CAR can secrete antibodies or ligands. And then the cell delivery vehicle. In this case, I've illustrated 3 possible examples of CARs: T cells, NK cells, and macrophages. But there's really a 4th dimension, which is time. How long the CAR engages with its target, its activation kinetics and expansion, which are usually hours to days, the systemic effects of CAR activation, which usually occurs over days to weeks, and the effect of the payload, which may be weeks to months to years. In Emily Whitehead's case, she still has CAR T cells in her body. They have prevented reconstitution of normal B cells, so she still has to get infusions of immunoglobulin, IVIG, in order to avoid sinus infections from B cell aplasia. I'll go through some examples highlighting a lot of the work that's been done on CAR T cells, but not ignoring other types of cell delivery cells and targeting molecules. So CD19 was the beginning of the modern era of CAR cells. It's an antigen expressed on B cells in normal B cell development. At the top of the slide, I show the progression from stem cells to pro-B cells, naive B cells, activated B cells, plasmablast plasma cells. And we see that CD19 is expressed really throughout nearly all of that spectrum. So from a commercial standpoint, if you develop a vector that can cause T cells to express an antibody to CD19, you have a potential drug that can treat a variety of different B cell malignancies. And the work at Penn began actually not with ALL, but with CLL. This is a paper from more than a decade ago that described 3 patients with CLL who received the anti-CD19 CAR. The structure of the CAR is shown in the cartoon on the left. This is in red is the single chain antibody encoding the recognition molecule for CD19. When these patients were treated, they had really a remarkable course with tumor lysis, uric acid, LDH, creatinine all spiked. That was associated with regression of the tumor from bone marrow packed with CLL to a normal hematopoietic reconstitution. You can see hematopoietic elements interspersed with fat and regression of adenopathy in the axilla. There was tremendous expansion of these cells in vivo. This is the measure of transgene copies on a log scale. So you can see there's 1, 2, 3, 4 log expansion. So 10,000 times increase in the number of CAR cells in the blood. And the high levels of these cells persist for up to 6 months, both in the blood and the bone marrow. And the flow cytometry plot shows in the blood before infusion, the CLL cells, which are co-expressing CD5, a marker present on CLL cells, as well as normal T cells, and CD19. And these CLL cells express kappa light chain, so they're a clonal population. After CAR T cells, the CLL cells are gone, normal T cells have been reconstituted, and there's no clonal population of CLL. So this was a success story for the initial 3 patients with CLL, but enrolling additional patients, results were not as promising, and Penn largely pivoted to treat ALL. This is their report from Shen and Maude in New England Journal a decade ago, describing the experience with 30 patients, mainly pediatric patients, including Emily Whitehead. The median age of these patients was 14, And among the pediatric patients, 3/4 had actually had an allogeneic transplant before they got the CAR T cell therapy. Emily Whitehead never did because she was too sick to have undergone allogeneic transplant. They had high-risk disease, multiple lines of therapy, but what was remarkable is that a fraction of these patients, about half, entered in remission, which appeared to be durable. And in fact, most of these patients had CAR T cells as their primary therapy, and the patients who achieved remission at 12 months tend to remain in remission. This led Novartis to license the technology from UPenn. Their commercialization plan then moved to diffuse large B-cell lymphoma because it's a bigger market. And the CAR, as I've expressed, targets a variety of different B cells and their malignant counterparts. We participated in the registration trial of Tisacel Lecluso, the Novartis brand CD19 CAR T cell. And we published our results with Stephen Schuster as first author, showing that all patients had about a 40% survival after getting this therapy, and patients achieved a complete remission initially, had about a 70% durable remission. Interestingly, the therapy worked in a force plot for all types of lymphoma patients, young or old, male or female, refractory or relapsed, more or fewer high risk factors, the two different subtypes of lymphoma, ABC and GCB, as well as patients who either had or had not had a previous transplant. So this was a game changer for the way we think about managing relapsed refractory lymphoma. This is one of our Emory patients. You can see adenopathy in the axilla, periaortic lymph node, and a very large mass in the thigh that completely regressed when she was restaged at 3 months after getting CAR T cell therapy. And this particular patient has remained in remission for the past decade. Well, this brought other companies into the field. Axicell was developed by Yescarta out of the NIH. Lysocell was developed out of work done at Memorial Sloan Kettering and Seattle. And both of these products have been approved as a third-line therapy. They appear to be superior to Tisacel, the Novartis product, in non-randomized comparisons of the patients enrolled on the various registration trials. Axicell is a bit better than Tisacel, but Axicell and Lysocell appear to be similar when you adjust in the gray curve for the particular characteristics of these patients. All three products then entered clinical trials as second-line therapy. That means patients who get initial R-CHOP for their lymphoma and then relapse, and instead of going on to an autologous transplant, move directly to the CAR T cell versus standard of care, where autologous transplant was the preferred modality. And for Axicell and Lysocell, there is a superior progression-free survival compared to the standard of care group, with about 40 to 50% of the patients getting the CAR T cell having progression-free survival, whereas patients allocated to standard of care, many of them never got to the autologous transplant, and overall only about a quarter of them achieved a durable progression-free survival. The similar trial for Tisacel, the Novartis product, failed to show a benefit for a variety of reasons, some of which was trial design. We've looked at our Emory experience with commercial CAR T, comparing outcomes for Lysocell and Axicell given as either second-line therapy at the first time of relapse or as third-line therapy, and looked at our outcomes for Tisacel as third-line therapy. And in contrast to our experience in the registration trial, our outcomes for Tisacel are not so great, but we see pretty good durable activity for the two alternative products, and we're shifting our clinical utilization now to these two products. All three of them are on formulary, and we're having at this point to make some decisions about which products to maintain on formulary, as the contracting and logistics to manage three products is too much. So can we improve upon this? Can synthetic biology further improve the activity of CAR T? Remember, synthetic biology is taking new things and putting them in cells to alter their function. The cartoon shows the different pieces that go into a CAR T. There's the binder, the single chain antibody that recognizes CD19, a spacer to move the antibody off the surface of the cell, a transmembrane domain that brings together the activation domain. So when the binder binds the antigen on the target cell, all of these different CARs are clustered on the surface of the T cell. And when these activation domains are clustered in a group, there's more tyrosine kinase activity to activate signals than phosphatases can remove, so the T cell is activated. This summarizes the different binders that are used, different spacers,
old people,
transmembrane domains, costimulatory domains, and T cell activation. And obe-cel, made by a fourth company called Autolus, used a different binder, similar spacers, costimulatory domains, that had different properties. And in fact, all of the currently approved CAR T cells use a strong binder. One would think that that's a good thing if the single chain antibody sits tightly on the antigen on the surface of the tumor cell, but that leads to really a very strong activation signal for the T cells, producing lots of cytokines that can cause toxicities that we'll talk about soon, CRS and neurotoxicity, and it can also lead to T cell exhaustion. The idea of a weaker binder is the CAR comes on and off the target tumor cell in a way that the levels of cytokine production are less and T cell persistence is improved. This particular product is given after lymphodepleting chemotherapy, fludarabine and cyclophosphamide, to reduce normal blood lymphocyte counts. And then it's given as 2 infusions, a low dose infusion on day 0 and a high dose infusion or higher dose infusion on day 9, again, to try to reduce the toxicity from this rapid 10,000-fold expansion of the CARs in vivo. And the data look pretty good. This is an adult ALL population, over 100 patients treated to date. Event-free survival is about 40%, but persistence of CARs is quite significant, much better than we see with some of the commercial products, such that CARs can be seen in the blood at significant levels out to 3 years after infusion. But most significantly, the toxicity profile using this weaker binder appears to be better. Grade 3 CRS, grade 3 ICANS are quite low and are proportional to the disease burden in the patient at the time of CAR infusion. So patients with low disease burdens had really no grade 3 CRS or neurotoxicity. We're not limited in treating B-cell lymphoma. CARs have been developed against multiple myeloma. Here, instead of using the B-cell antigen CD19, they use a plasma cell antigen called BCMA. 2 different products are commercially approved. Cilta-cel, which is actually started in a Chinese company called Legend. It's subsequently been acquired by Janssen, and they have a single chain antibody that has 2 different antibodies to the BCMA protein on the cell surface. So these antibodies can bind, release, and they think that that gives a higher potency compared to a standard of care group for lenalidomide refractory multiple myeloma patients. There's a clear improvement in progression-free survival, whereas ide-cel with a single BCMA binder improved progression-free survival, but ultimately all of their patients relapsed. And our program in the myeloma group has been moving towards increased use of cilta-cel for this reason. CARs are not limited to treating B-cell malignancies. This is a report last year from the New England Journal that is targeting T-cell lymphoma and T-cell leukemia with CARs. Now you can imagine there's a bit of a conundrum. If you want to have a CAR attack a T-cell, won't it attack itself because it's identifying a T-cell antigen? In this case, the CARs are modified to eliminate a number of T-cell antigens, the T-cell receptor, CD7, which is a surface protein on T cells, and CD52. And that's done through base editing, changing the codon for amino acids in these different proteins to a stop codon. So the CAR expresses an antibody to CD7, but lacks CD7 itself. So it doesn't cause fratricide. And here you can see in a patient with T-cell ALL, massive expansion of the CAR in red. Again, multiple log orders of expansion. After allo-BMT, the CARs were eliminated and normal reconstitution of T cells, B cells, NK cells occurred. So we've looked at antibodies as the way of modifying these cells. Cells can also be modified by putting in a transgenic T cell receptor. In this case, the T cell receptor is identified from patients who had a T cell response to a cancer, and that T cell receptor is going to recognize a specific peptide. This is an example from a couple years ago at the NIH that looked at a T cell receptor that recognized a mutated KRAS protein. KRAS is one of the oncogenes mutated commonly in cancer, particularly in pancreatic cancer. In this case, the mutated peptide is expressed by an HLA molecule, class 1 molecule on the surface of the cancer cell called HLA-C0802. The T cell receptor recognizes the complex of the peptide in MHC class 1 and kills it. And this was effective in eliminating cancer from this particular patient. And these cells persisted again for up to 6 months after infusion. This is a much more customized approach because it will only work, this particular T cell receptor is only going to work for patients who express this particular HLA molecule. So companies are trying to generate CARs restricted to HLA molecules which are common in the population, particularly HLA-A02. And in this case, actually, the T cell receptor recognized two different, they used two different versions of the T cell receptor that recognized a 9 or a 10 amino acid peptide derived from KRAS. So beyond receptors, CARs can be generated by expressing of ligands. This is an example of a autoantibody reactive CAR T cell to treat autoimmunity, published by a dermatologist who's been working with autoimmune. And in this case, the CAR is genetically modified to express desmoglein, which is a protein that normally holds skin epithelial cells together. That protein is
all of you guys have no fear.
That protein is identified by an antibody present on autoreactive B cells in patients with pemphigus.
Shut up, old man.
You treat patients with pemphigus with the T cells that express the ligand. Potentially, they have the ability to react with and kill the autoreactive B cells. And this is mouse data that was published showing that mice with pemphigus that got the desmoglein CAR had normal skin, whereas mice that got control CAR had bullous lesions on their skin. This was taken into clinical trials. It was not effective in humans as it was in mice, but the principle, I think, is still quite valid. The company that's doing this has moved on to use a CD19 CAR. NK cells can also be the substrate for chimeric antigen receptor modification. These are usually currently being targeted to treat tumors. This is an example of a NK cell CAR that expresses an antibody to CD19 as a single chain. It has the similar co-stimulatory molecules as we've seen in the CAR T cells, but with the addition of IL-15, a cytokine to stimulate the expansion of NK cells in vivo, and then a safety switch, inducible caspase-9, so that if these NK cell CARs got out of control, they could be eliminated by adding a ligand that would bring two of these caspase-9 molecules together, triggering apoptosis of the CAR. In this particular study, 11 patients with different flavors of lymphoma were treated, and 7 out of the 11 had progression-free survival, although some of them had consolidation in the orange bar with allogeneic hematopoietic cell transplant. So again, another approach to treat patients with genetically modified cells. And the third and final approach I'll mention, which is earlier in development, is using macrophages as the cell effector cell population. In this case, expressing on the surface of the macrophage an antibody to HER2. And this is preclinical data looking at a ovarian cancer model whereby the macrophage expresses an antibody to HER2. It has the CD3 stimulatory domain without co-stimulation. The genetically modified macrophages phagocytose the tumor cells, and again in mouse models, they produce a more durable remission of human ovarian cancer in immunodeficient mice compared to control mice that got PBS or an irrelevant construct. So this is being commercialized actually by a company that Carl June founded, and we'll see how this develops as an alternative to CAR T cells. So those are some of the success stories, both clinical and preclinical. What about some of the limitations of CAR? Well, there are problems with not being able to harvest enough cells or manufacture sufficient cells to give to the patient. I'll talk about our own experience with Novartis that led us to develop some new technology to address that problem. CARs may not live long enough in vivo or expand to sufficient levels to eradicate the tumor. The tumor cells may downregulate the antigen, a particular problem with B-cell ALL, and the CARs may cause some pretty scary toxicities. Severe cytokine release syndrome looks like very bad sepsis. Neurotoxicity can be quite frightening for patients, leading to aphasia, coma, or even death from brain herniation. And there are other types of tumors that are not currently being treated with CARs. So let's look at cytokine release syndrome first. This is when CARs produce large amounts of cytokines, interferon gamma. IL-6 can be also released by activated T cells, macrophages, or endothelial cells, and this can cause this sepsis-like syndrome with increased vascular permeability, hypotension, tachycardia, fever. Neurotoxicity can ensue when the vascular permeability involves the brain, and that can lead to delirium, aphasia, seizures, edema, and hemorrhage. So cytokine release syndrome, cytokines, they usually occur within the first 2 weeks after cell infusion, usually around the time the CARs are peaking in the blood, and they present, as I've described, typically first with fevers and then with hypotension. This is the incidence of grade 3 cytokine release syndrome in the commercially approved products for lymphoma, the Kite product, Axicell, the Novartis product Tisacell, and the Juno product Lysocell. And you can see there are differences across these products, with grade 3 cytokine release syndrome being in the teens for these two products, but only 1% for the Juno product. The Juno product separated the CD4 and CD8 CAR T cells, manufactured them separately, and then recombined them into the product. And the levels of neurotoxicities, grade 3 neurotoxicity, are also in the 20% range for all these products. About half these patients or 20 to 40% of these patients got tocilizumab in the registration trials. About 20% of them got steroids. Currently, our management of cytokine release syndrome is to give tocilizumab when people have fever, even if they're not requiring vasopressors, because it works so well and it does not appear to have any negative impact on the efficacy of CAR T cells. If patients progress after multiple doses of tocilizumab with persistent fever requiring multiple vasopressors, we'll give additional antibodies to other cytokines like anakinra, and we'll give steroids if they don't respond. This is an example for those of you who haven't seen a patient with cytokine release syndrome. of a lymphoma patient that developed high fever after getting Yescarta Axi-cel for their lymphoma. In blue is the temperature curve. Their temperature goes from 37 degrees up to 39. We see patients even as high as over 40 degrees. They got 3 doses of tocilizumab, and then the fever abated. Concomitant with this, they had some neurotoxicity. One of the very simple ways we manage or we follow neurotoxicity is to ask patients a series of questions, where they are, what the date is, what to remember a number of objects, but also to have them write. And it's very interesting that the act of writing uses lots of different brain functions. You can see that they're unable to coherently write a sentence. Their handwriting is terrible, but with tocilizumab and steroids, their brain function returns, and in fact, their lymphoma goes into remission. But it can be very scary for patients, for their family members, when they're in this ICANS or immune cell associated neurotoxicity, because they cease to be people. In fact, they may become completely aphasic for hours or even days. We know that the neurotoxicity is a function of expansion of CAR T cells. This is an example of Yescarta, where you see 1, 2, 3, 4 log expansion of the cells in vivo. More neurologic events were found in patients with higher levels of expansion, and higher levels of expansion were associated with more cytokine release syndrome, as well as response rates for this particular product. Some of the neurotoxicity is mediated by GM-CSF. Activated T cells can make GM-CSF another cytokine, and that can lead to neuroinflammation. And one approach to deal with that is to give an antibody to GM-CSF. It, again, has no negative effect on CAR T cell function, but it can reduce neuroinflammation. You can see for patients with grade 3 ICANS or neurotoxicity, they had higher levels of GM-CSF in their blood than patients who had no or less neurotoxicity. And here's mouse data to show that CAR T cells in blue were associated with increased leakiness in the endothelium in the brain with gadolinium present in an MRI scan, whereas the same mice who got CAR T cells treated with an antibody to GM-CSF had reduced levels of gadolinium. And this is, again, an approach which is being commercialized. In our own experience, in our published experience with the Novartis product, we didn't see the same association between the dose of cells infused and the maximal number of cells measured in the blood. And that is really an important take-home measure. When we normally think about drugs, there's a dose response. We give a little bit, we see a pharmacological effect, blood pressure is not under good control, you increase the dose of a beta blocker. CAR T cells, because they expand so much in vivo, and there are differences in the quality of CAR T cells from one patient to another, the expansion of the cells and the maximal content of the cells in the blood has a very poor relationship to the number of cells we infuse. So it creates a problem in dosing, and traditional dose intervals don't make as much sense with CAR T cells as they would do with other drugs. One of the medical students working in my lab, Fanyuan Zheng, has looked at some of the covariates to predict outcomes in Emory patients, identified the level of IL-7 on day 0 before CAR T cells are infused, but after patients get the lymphodepleting chemotherapy as being associated with a higher probability of survival. So patients with higher the median level of IL-7 had better survival than patients with low IL-7 levels. And IL-7 is known to drive CAR T cell and T cell expansion and persistence. This is a dozen patients who had a variety of different lymphomas and received a variety of different commercial products. Well, what about the idea that CAR T cells work better when they live longer? And we came to this problem actually through our clinical experience with Novartis. We enrolled 15 patients with lymphoma to be treated on the clinical trial, but only half of them actually got the CAR T cells. For the other patients, Novartis called us up and said the CAR T cells didn't grow. In fact, they said, you must be doing something wrong in the pheresis procedure to collect the T cells. And I said, pheresis is pretty standard. I think it's a function of the patient and the manufacturing, not the pheresis. They actually came out, audited our program, and they agreed the pheresis is standard and that there was something else going on. When we think about T cell development, T cells move from naive T cells that have not seen an antigen to a stem-like population, to central memory T cells, effector memory T cells, and finally effector cells. And there are different antigen patterns that are associated with these different stages of T cell development. But I'll bring your attention to these two co-stimulatory molecules, CD27 and CD28, which are present early in T cell development and lost as T cells undergo terminal differentiation. The terminal effector cells are good at killing cells, but are short-lived. The long-lived cells have a higher proliferative capacity. So one of the problems with lymphoma patients we discovered, published in a paper by Chris Peterson, one of my graduate students at the time, is that healthy people have lots of T cells that express CD27 and CD28. These are the good T cells. Patients with lymphoma who've never been treated have lots of good T cells, but heavily treated lymphoma patients, the T cells lose these important co-stimulatory molecules and they accumulate a population of senescent or bad T cells, so that the fraction of T cells that lack both CD27 and CD28 goes up in heavily pretreated lymphoma patients. In fact, that fraction is proportional to the number of individual cycles of chemotherapy these patients have experienced. This has a dominant negative effect on the activation of the rest of the T cells. So if we deplete the bad T cells from these patients' blood and then try to expand their T cells in the laboratory, the T cell population, which is depleted of the CD27 negative, CD28 negative cells, grow better than the undepleted population, and the purified bad T cells don't grow at all. So this led us to ask the question, what can we do to improve the ability of CAR T cell manufacturing, given that we're dealing with a substrate of patients who, through no fault of their own, we've been giving them chemotherapy for a couple of years, we've made their T cells senescent. And with Ronnie Funk, who at the time was an Emory medical student, went on to work in my lab for a year and a half after getting a grant from the Howard Hughes Medical Institute. We hypothesized that adding a PI3 kinase inhibitor, duvelisib, during CAR T cell manufacturing could improve the functionality of the T cells. And we thought about this because at the time when PI3 kinases were being used to treat lymphoma patients, doctors were seeing lots of autoimmunity among those patients, particularly pneumonitis or colitis. So I reasoned that duvelisib was an immunomodulatory drug, and it would address the problem of high frequency of senescent T cells in lymphoma and in CLL patients, and a low frequency of naive cells. So Ronnie showed in a paper published a couple of years ago in Blood that treating CLL T cells, or T cells from a CLL patient with duvelisib in vitro over a 10-day period could increase the fraction of naive T cells in the product. He used this approach to manufacture CAR T cells and showed that duvelisib increased the green population, CD8 central memory cells, and the red population, naive CD4 cells, compared to T cells expanded without duvelisib, and that these duvelisib expanded T cells had more gene upregulation associated with T cell receptor function. They had evidence for epigenetic modification with increased content of mitochondria and more oxidative phosphorylation. And when Ronnie manufactured T cells with developed in blue or without developed in green, whether he used a CD28 co-stimulatory domain or a 4-1BB co-stimulatory domain, and gave these T cells to immunodeficient mice with a human CLL cell line, a greater proportion of the mice were cured when they received the developed expanded CAR T cells, and there was much greater expansion of the CAR T cells in the mouse and much more persistence compared to CAR T cells manufactured without developed. In fact, when we first saw those mice, 90% of the leukocytes in their blood were CAR T cells. I thought they were going to die of leukostasis, but they survived, and half of them or more were cured. Interestingly, the levels of immune suppressive molecules LAG3 and TIM3 were also lower on the developed expanded CAR T cells than conventionally manufactured T cells. So this is another approach to achieve a similar thing, now knocking out adenine methyltransferase, DNMT3A in CAR T cells that prevents the exhaustion of those cells and enhances their anti-tumor activity against osteosarcoma expressing HER2. I highlight this paper really because Chris Peterson, who was the graduate student in my lab, went on to do a postdoc at St. Jude and continued his interest in trying to find better CAR T cells, showed with others that the DNMT3A knockout CAR T cells were able to prevent tumor growth in a fraction of mice. This is looking at bioluminescent imaging of tumors as they grow in the mice, so more tumor cells, more light being admitted in the recipients of knockout T cells. A fraction of the mice are cured. So this is, again, something that is of interest to try to bring forward into clinical trials. Well, what are we doing at Emory today, and what will we do at Emory tomorrow? Probably our first foray into local manufacturing is being led by Jane Koff, one of our associate professors in the Department of Hematology Oncology. She's using a basic platform of CD19 CAR T cells, but manufacturing those in a closed system using a commercial box called Clinimax Prodigy that can sit inside our GMP lab in the tower building of EUH and decrease the time it takes from vein to vein, from the time we apheresis the patient for CAR T cell manufacturing to the time we reinfuse the CAR T cells. Jean believes that can be reduced down to 12 days versus the 4 weeks or more that is present with the commercial product. And that will be, we hope, soon the first example of a locally manufactured CAR T cell product using the Excite laboratory. What about going back to synthetic biology? I told you there's these first, second, third generation of CAR T cell, but I also intimated that CARs can do other things. We can add other genes that are activated only when the antibody binds to the receptor, such that there can be a secondary effect of new gene activation, transcription, and translation of proteins. And this is a published approach looking at treatment of glioblastoma with something the authors called SynNotch, using Notch as a transcription factor, such that when the primary antibody binds the target, here EGFR V3, a antigen present on glioblastoma cells, that the transcription of a second CAR is then induced, targeting 2 other proteins which are expressed on glioblastoma but not restricted to glioblastoma. So to get around the problem of specificity, you localize production of the CAR only at the site of the tumor, such that if you treat a mouse that has a mixture of EGFR V3 positive and EGFR V3 negative tumors in the brain, and it also has a second tumor that's EGFR V3 negative, the brain tumor is treated in red by the CAR T cells versus control in black where the tumor grows. Whereas the flank tumor that is EGFR V3 negative, there's no difference between CAR and control. So this allows us to fine tune where the CAR is being activated in the tumor microenvironment. Another approach is to put a backpack of cytokines onto the CAR, approach being developed by Sarwish Rafiq and her graduate student, Heather Lynn. They screened a variety of different cytokine combinations in a high-dimensional screen, identified particular concentrations of IL-2, IL-7, and IL-15 that led to a higher proportion of naive-like T cells after CAR manufacturing, and a higher fraction of mice that could be cured of lymphoma when they received the CARs with the cytokine backpack packaged into nanoparticles versus control CARs that didn't have that benefit. An additional approach by the same group, and this is work that I'm also collaborating with, is to cause expression of an antagonist to VIP receptor in the CAR. So VIP is a immune checkpoint pathway that dampens the activation of T cells. Sarwish and Heather have engineered the CAR not only to express an antibody to the cancer target, but also to express a peptide antagonist to the VIP receptor. And these CARs are more naive, a good thing again. They have more CD62L, more CCR7 expression, but more importantly, they're more potent in controlling the growth of human pancreatic cancer in an immunodeficient model, such that the tumor volume is less than in control CARs that have the same antibody but lack expression of the VIP receptor antagonist, and average tumor weights are significantly lower. We also have a second project in the pancreatic cancer space done as a R01 MPI with Crystal Paulus and Greg Lazinski, with Carl June from University of Pennsylvania as a collaborator. And here we go back to Ronnie's idea of using Develisib, the PI3 kinase inhibitor, to expand a more naive, persistent CAR T cell population, and use Crystal Paulus's findings that CD4 cells that express CD26 produce a multifunctional CAR T, which is able to potently enter the tumor microenvironment and recruit other T cells into pancreatic cancer. This is funded by an R01. The third aim is to do a phase 1 clinical trial at Emory using these cells that are manufactured with Develisib, selected from patients' T cells for the subpopulation of CD26 high. And Carl has given us 2 lentiviruses so we can barcode either the CD8 population, which is not selected, or the CD4 population, which is selected on the basis of CD26 expression, combine them, and then use DNA PCR amplification to detect each individual CAR population in vivo. Well, what are the frontiers in the future? I think we're all hoping for off-the-shelf allogeneic CAR T so we can bypass some of the limitations of CAR manufacturing. There's a lot of interest in using CAR T cells expressing a CD19 antibody to treat autoimmune disease, and a number of studies will open at Emory. My colleague, Shun Ukandran in pediatrics, has developed CAR T cells that express the ligand for c-MPL, or the thrombopoietin receptor, that could be used to ablate normal stem cells in the bone marrow of a patient with sickle cell disease prior to transplanting genetically modified hematopoietic stem cells that won't produce hemoglobin S. And we could potentially use CARs for directing a variety of drugs to different tissues for local delivery of peptides or proteins. We could have CARs producing semaglutide to treat obesity if we're targeting the CNS. We can have CARs expressing VIP antagonists broadly to treat cancer, or we could maybe even use CARs that express anti-amyloid monoclonal antibodies to treat Alzheimer's. So I'm sure all of you in your careers, whether they're beginning or whether you're established already as a physician at Emory, we'll see CARs for non-cancer indications. And I hope that I've given you a little bit of background about how they work and what some of the issues are. I'll acknowledge sources of funding, Emory, the Katz Foundation, Novartis, Veristem, NCI, and Howard Hughes Institute, and then highlight the people who did some of the groundbreaking work at Emory: Shuhao Wang, Ronnie Funk, currently a HemOnc fellow, formerly a Emory Department of Medicine resident, Jean Koff, Greg Lazinski, Crystal Paulus, Heather Lynn, a graduate student, and Sarwish Rafiq. I'd be happy to take any questions.
Ned, thank you so much. I will tell you that in the midst of that, sorry for the outbursts, we got hacked, so the chat has been disabled, so you won't see messages in the chat. And we are almost at the top of the hour. I just wanted to ask you, and if anybody has a quick question, feel free to raise your hand and I will selectively unmute you. This is so exciting, and the range of disease processes that you've described is that where this may be effective is remarkable. And but the question is, I think, about equity and access and cost and turnaround. I saw that today the FDA approved sort of a slightly faster turnaround process for a Gilead product and so on. But how accessible do you think this will be for people with all sorts of issues rather than a few niche kind of refractory disease processes?
So one issue is to make the cost less. I think Jane and Madhav Dodapkar's idea in developing the homegrown CD19 CAR is not necessarily to do groundbreaking science with that platform, but be able to manufacture cells locally without having to charge people $400,000 or more. Allo CAR T, because they can be manufactured in bulk from a limited number of donors, potentially can reduce the cost by a factor of 10, so that we're talking $50,000, not $500,000. Companies, have basically are not willing to give the cells away for free. That is a problem. I mean, with a regular drug, they can have some kind of program for people who don't have insurance. That hasn't occurred for CAR T cells, although it is available for patients with sickle cell disease, and Medicare, Medicaid will cover gene therapy for sickle cell. So I think part of the answer, Wendy, to your question is cheaper drug production, and part of it is patient selection. So we're giving the drug, an expensive drug, to people who are really going to benefit from it, and part of it is expanding coverage.
All right, and since we have one raised hand, we'll take one more question from David Solano. And here you may or may not have the pot there.
Hello, can you hear me?
Yes.
I can, yeah.
Oh, no, I had kind of two questions. So one of them is for the CAR T cell therapy. Do you know how they genetically engineer the T cells to be with the chimeric antigen? Do they use lentiviral vectors or?
So almost all the commercial products use lentiviral vectors, yes.
Okay, and my second question, thank you for that, was I was reading on the news the other day, and there was an NBC article that was saying that the FDA now had required that a lot of, I think Novartis products, especially with CAR T cell therapy, required a boxed warning that CAR T cell therapy can cause or promote cancer. And
So there's 18 cases of secondary cancer reported out of probably 30,000 people who've gotten CAR T cells. Anytime you mess with cells, you can do bad things. And if you take a T cell population and genetically modify it and then give it back to patients, there's the possibility that you could create a T cell malignancy. In fact, in some rare cases, T cell malignancies have been seen in CAR T cell recipients, but it is rare. And those are people, when it was looked into, that had a pre-existing clone of T cells prior to CAR manufacturing that was presumably the substrate for the subsequent malignant population that grew out. So it's a risk. When we see people with lung cancer, we tell them the chemotherapy we're going giving them could cause leukemia. And that's a higher rate than we see secondary malignancies in patients who've gotten CAR T cells. But we would like to not to have that problem at all. And I think patients certainly should be aware of the risks of any therapy that they're being offered.
Thank you very much. I was really hoping for like to know if there was any merit to that. And I really appreciate it. Thank you very much.
Sure.
And I think now we're past the hour, so I want to thank you very much. This again, as promised, taught me a lot, and so and it makes you really excited for the future. So
Great.
thanks,
Great
Ned.
to see you all. Bye bye now.
Bye.